Gabby, are we good to start?
Hello.
Hi, good morning.
Good morning. Good morning. Welcome to everybody. Thank you, Catherine, for still providing us with this great information. We do have a few people here at the office, at the Immaculate Heart offices, but many of you are on Zoom, and this is the second to our the second to our last conversation about these topics. More to hopefully come. But welcome everybody, and we look forward, Catherine, now to hear your presentation.
Can everybody hear me okay? Okay, so this morning we're going to be having a conversation about medical interventions, the ethics of living and dying. I know this is a topic that everyone's been curious to learn more about, so I look forward to sharing my work with you today. Hope everybody can hear me all right. So let's begin with kind of reflecting on the life that we have here in the final journey. We're growing older, and this invites deep reflection on life, typically, suffering, and death. Advances in medicine bring difficult decisions: when to treat, when to let go. And also, I want to add, it's not on the slide, discussions around different interventions, different medical models. And what about our faith? Our experience and conscious guides us through these choices. So all of this is very typical when people are facing kind of end of life. And I'm not saying being older, I'm just saying end of life issues. When life is kind of coming to an end, we look at that. So let's talk about medical interventions near end of life. So the common treatments and supports are CPR, feeding tubes, mechanical ventilation, and pain management. So each intervention has its benefits and its burdens, and we're going to talk about this. And I really want to make sure that people understand what
Hi,
CPR.
Catherine. Sorry to interrupt. Are you trying to share screen?
I have been speaking. Can anyone hear me?
We can hear you. We just don't see the presentation yet.
Yeah, let me go to the beginning. I have been. It is not allowing me to share screen right now.
Remember, just go back to the Zoom window.
Yep. Hi, everybody.
There we are. Thank you.
Great. Can you all see my presentation?
No, just as the thing with your file names on it.
Okay. Gabby, it says that I'm sharing screen.
You're good. Just double click on the medical interventions file. First file up top.
Mm-hmm. Okay, hold on, everybody.
It's right
Yep.
there, that first
There.
one. There you go.
Blocked. It's been blocked. Okay, very good. Can you hear me? And does everyone see the first slide?
Yes.
Great. Okay, we're going to start from the beginning. Okay, today we're going to be talking about medical interventions and the ethics of living and dying. Gabby, the screens are not advancing. Gabby, can you hear me?
Here. Let's try that button next to the title. Remember, it's a single page.
Yeah, and we're going to go down to single page was clicked already.
try your
How
keyboard.
about that?
There it is. There you go.
Okay. So can everybody hear me and does everybody see the slides moving? Okay. Gabby, can I start again?
Do. We're
Can
we're
everybody
watching you, and
hearing me? Okay, I'm going to start.
yes.
Medical interventions. So let's go back to reflections on life more at the end of life. Growing older invites deep reflection on life, suffering, and death. We talk about medical decisions and advances in medicine, difficult decisions to look into when to treat and when to let go. And also our faith experience and making conscious decisions about this. Okay, hold on, everybody. I'm opening my screen. Sorry for the audio visual technology issues. Gabby, I'm going to need your help again. The presentation has disappeared.
We see it on our side.
So
Let's see.
Gabby, I can see my presentation. However, the views of everybody on the far right hand are blocking my presentation, so I can't read
I
everything.
can minimize that. There's a button.
Okay, just did it.
You did. Okay.
Perfect. Okay. All right. Medical interventions near the end of life. So common treatments and supports that we see often are CPR, feeding tubes, mechanical ventilation, pain management. And each intervention has its benefits and its burdens. So let's talk about CPR. People often, when they are completing their end of life advance directives, which stands for advancing, giving an advance directive to somebody when you can no longer make your own medical decisions. So this is really, we're looking at end of life decisions. So the benefits of CPR is that it can restart the heart after sudden cardiac arrest. So everyone is on the same page. The definition of death is when the heart stops. Okay? So you can be in a tragic car accident and be in a coma the rest of your life and be declared as brain dead, but you're not dead because your heart is still beating. Okay. And those are, we'll talk about choices about that, staying on, ventilation or hydration ongoing. So the benefits of CPR at end of life is that we can restart the heart after sudden cardiac arrest. May save life in otherwise healthy individuals with reversible causes. And it's quick, it's fast. Anybody can do CPR. It doesn't have to be somebody that drives an ambulance or a physician. Anybody can do CPR. CPR today, there used to be specific rules about mouth to mouth and heart, pounding on the heart. They got rid of mouth, reset. You don't have to do mouth. So you can just hold your hands and pump on the heart, and you can just pump. And that's what they say today, paramedics, physicians, healthcare systems, is just pump in the center of the ribs because the goal is to get the heart to restart. What are the burdens to CPR? Often it's not effective in older people or frail patients, and the survival rates are very, very low in these groups, very low. Oftentimes, and you could ask anybody who is in paramedics, oftentimes CPR will cause physical trauma. So maybe not me doing CPR on you would cause broken ribs and internal injuries, but I can tell you if a paramedic, you're on the ground and a paramedic starts performing CPR with the goal of starting your heart back up, he or she is most likely going to break your ribs and cause internal injuries. You may or may not wake up from that and survive that. Also, a burden of CPR is that it may lead to prolonged life with poor quality of life, or you may be in a vegetative state. Those are all risks and the burdens to CPR. And what it can also do is delay natural death without improving your outcome. So when people say, well, what's dying? What's a natural death? Well, a natural death is when your heart stops beating. That's considered a natural death. So there's a delay on my end a little bit on moving my pages, but so please bear with me. Okay, let's say you don't want CPR, okay? And let's say that you're more at end of life and you want to have eternal or internal nutrition and feeding tubes, okay? And that's your right and your choice. So there's benefits to that. It's going to provide nutrition if a person cannot eat by mouth. It may be useful short term during recovery from a surgery or illness. We see this often, right? Where it's short term, very defined short term, and then we take the person off the feeding tube, and ideally the person wakes up and eats on their own. And it can prevent starvation in certain acute conditions, okay? So what are the burdens of feeding tubes? In chronic or terminal conditions like advanced dementia, advanced cancer, often this does not improve survival or comfort. And especially in regards to neurocognitive diseases like an advanced dementia, and we're talking any kind of dementia, not just Alzheimer's, any kind, we often see that there's a confusing element, high anxiety, and very rare quality of life. It can cause discomfort, infections, and aspiration pneumonia. It may prolong the dying process without improving quality of life. And it can feel invasive or undignified for some individuals. And there's another element here that I did not add is that where are you going to be living when you have feeding tubes? You're either going to turn your house into a hospital, and it's very expensive. Round the clock nurses because they have to clean the wound and all of that. Or you're going to be going into a skilled nursing facility, which is paid for by Medicare and often is quite substandard to what one is used to. So, and then there's pain management, palliative medicine, okay? Keeping you comfortable. So the benefits of palliative care is that it controls the physical suffering and improves comfort. I don't know anybody that has said that they prefer to suffer. I don't know that many people that prefer that. People want comfort. People don't want to be at pain at all, at any time, especially at end of life. And your loved ones do not want to witness the pain you're in. It's very, very painful for someone to witness that. Pain management enhances quality of life, especially in terminal illness. I'm going to give an example. Let's say the doctor has ordered hospice or palliative care. You're in the comfort of your own home. And quality of life means you can be on your porch watching birds or in front of a fireplace drinking hot cocoa. It's whatever you want it to be. That enhances this pain management. It can support emotional and spiritual well-being. I know many people that are on hospice, depending where they are in their phase of hospice, and they're being maybe wheelchaired into mass on Sundays. So it's supported by Catholic teaching, even if it may unintentionally shorten your life, as long as the intent is comfort, not death. What are the burdens to pain management? It may cause drowsiness or reduced alertness. It's the risk of medication side effects or interactions, and it may require careful monitoring, especially in frail individuals. So, ethical principles. So, autonomy. We want to respect the patient's choices. Very important, autonomy. We want to do good for the patient. We just don't want to obviously have them administer a medication that may not be in the best interest of them. And we want to always avoid harm to the patient or to ourselves. And what about justice, fairness and care and resources? So these are key ethical principles that we talk a lot about in the work that I do. So ethical principles in Christianity, human dignity. Every person is created in God's image and deserves respect. Stewardship of life. Life is to be preserved, but not by extraordinary means that may cause suffering. In regards to hope and resurrection, faith in life, it shapes how Christians approach death. And compassion, care for the sick and dying reflects Christ's love. So those are the strong ethical principles in Christianity. So what about other religious groups? What about Islam? What about those other ethical principles? Sanctity of life is very important to the Islam faith. Life is sacred and it belongs to Allah, and it must be protected. Another principle is submission to God's will. Medical decisions are made in trust and surrender to divine wisdom. A principle of no harm, avoiding treatments that prolong suffering without benefit. And with Islam faith, community and prayer, family and faith leaders help guide end-of-life choices. So let's talk about Hinduism and how they view life and death and the ethical principles. So first of all, I may not pronounce every word correctly. Ahisma is non-harming, referring to actions should avoid causing pain or distress. Karma, one's actions, including care decisions, affect the soul's journey. We've all heard of karma before, very important ethical principle of Hinduism. Detachment, letting go of the body and worldly attachments is part of spiritual growth. And sacred dying. Dying rituals and calm surroundings support the soul's transition. So you can see differences already in the ethical principles of some of these religious beliefs. Buddhism, these are very important for the Buddhist, for those that are Buddhists. Compassion is one of their number one ethical principles, that care should be offered with kindness and without causing harm. Mindfulness, conscious awareness at death supports a peaceful transition. The right intention, decisions should be made with moral clarity and loving concern. And in permanence, acceptance of death as a natural part of life which eases suffering. And in regards to Judaism, their principles that are very important is, I'm not sure to pronounce the word correctly or the phrase, but it's preserving life is a central duty in Judaism. Dignity of the person, life and death decisions must honor the individual. In regards to balance, treatment should not prolong suffering or delay the natural process. And the Jewish law states that ethical and holistic decisions are guided by religious law, rabbinic counsel, and medical practice. I used to work at Cedars-Sinai Medical Center, and we would often treat many Jewish families, often very conservative, some Orthodox, and we made decisions, or I should say I was part of the bioethics team at the time, where families and doctors and rabbis made decisions depending on certainly saving life, but looking at the timing of when do we make a life-changing decision? For example, is it okay to have a surgery on a Saturday, which is Shabbat? Or is it okay on Shabbat to end one's life and take them off life support? So in the Jewish faith, I can share there was a multitude of decisions that involved the rabbi, the doctor, and the family. And that was very, very critical and important for the family to make those decisions on certain days of the week. So when we talk about advanced directives and do not resuscitate orders, that's DNR, do not resuscitate. That means do not perform CPR on me. I want to die naturally. So advanced directives and DNR orders, this is planning ahead. That's all that this means. I have an advanced directive disorder where I have my daughter, who's 25 years old, as my decision maker if I can no longer make my own medical decisions for me. And I have that specifically drawn out. The worst thing that you can do as a parent and as a close friend to anybody, let's say one does not have children, is to not have an advance directive and to not communicate them at least what your wishes are. I think it's one of the important things that you can do. So we have living wills, and that's something that one can draw up with an estate planning attorney. There's something on the internet called LegalZoom, where you outline what your will is now. This is like while you're living. The next one, durable power of attorney for healthcare. That is an interchangeable term with advanced directive. And I know sometimes this gets confusing. There's two types of durable power of attorney. There's one for healthcare, which I just gave an example of. My daughter is my decision maker if I can't make my own healthcare decisions. Then there's also a document called a durable power of attorney financial. That's where if I can't make my own decisions about paying my mortgage, paying my light bill, trash, all of that stuff, my Amazon, anything that has to do with money, who's going to do all that if I can't? If I'm in a coma, if I have advanced dementia. One of the most dangerous things is that people end up having advanced dementia and they haven't put any of this in place and they have to pay their rent or they have to, who's going to take over all that? Big decision and big responsibility, but you want to know now so you can manage those things. And then there's the do not resuscitate orders, which I spoke about. So let's talk about euthanasia and physician-assisted dying. So definitions. Euthanasia is the act of intentionally ending a person's life to relieve suffering, typically performed by a healthcare provider. Okay, and we all know examples of this. Doctors who have performed this that have gotten in trouble because of this. And different states in the United States approve of, by law, different courses of action. So let's talk about physician-assisted dying, PAD. This is when a doctor, a licensed physician, provides a patient with the means. It's typically a prescription for lethal medication to the end of their life, but the patient takes the final action themselves. So in the state of California, we have something that's called the Right to Die Act. And I believe it came into law, I'm going to say 5 to 10 years. And it's a very interesting law. And I believe the first state was Oregon. So in the state of California, what the law states is that if you don't have mental illness, like if you're not suffering from a severe depression where you're suicidal, number one, you have to be within the last 6 months of your life. That's determined by the doctor. The doctor states this. And you don't have any kind of cognitive impairment. You can't have dementia. So a lot of people say, well, I want to do this, but I have dementia, so I can't. So the law says you can't. So you have to be cognitively intact. You have to have 6 months of life left, and you have to not be depressed, and you have to be able to say, doctor, I want to do this. And this is the law today, and this can be done. I had a friend's mother do it a couple months ago. She was just ready and she made that decision, gathered her family all around. They all watched her take the lethal pill and she went to sleep. And that was her choice. So key characteristics, euthanasia, medical profession directly administers the means of death. Intention is to end suffering by causing death. It can be voluntary, non-voluntary, or involuntary, all of these things against the patient's wishes. That is 100% unethical, often illegal. So no adult child who sees their loved one, in pain, can do anything like this. That is considered murder. It's legal in only a few countries, euthanasia. Physician-assisted dying, the patient must be voluntary, meaning, yes, I want to do this, and consciously choosing to take the medication. The physician's role is limited. He or she's only prescribing, like you're literally prescribing and you're going to CVS and you're getting your medication to end your life. The doctor is not administering. The doctor is not present at the time that you self-administer. It requires that the person's terminally ill, mentally competent, and meets strict legal criteria. It's very strict that you got to cross off all the boxes. And it's legal in some US states, Oregon being number one, California number two, often under the term medical aid in dying. From what I understood, that when it passed in California, the Right to Life Act, approximately 400 people the next day made this decision and carried through. I don't know what the numbers are today since it's been in law. So religious and cultural perspectives, we want to consider how beliefs shape our decisions. And it's very important to look at your religious belief, maybe the laws around that, your spiritual decisions, your, I think, relationship with God, all of these things you want to look at. Varying views on suffering, death, afterlife, right? Importance of culturally sensitive care. That's really important. Culturally sensitive care. I know a lot of people that are from, different countries that don't speak English and they want a caregiver that speaks Farsi, a caregiver that speaks Chinese. That is culturally sensitive care. It makes a big difference. You have to take all of that into account. So let's look at religious understanding of life and death. Catholicism, understanding of life and death. Life is sacred. It's purposeful. Each person is made in the image of God. According to Catholicism, death is a natural part of life due to the original sin, but conquered by Christ's resurrection. And the view of end of life is that life should be respected and preserved, but excessive or extraordinary means to prolong life may be morally unnecessary. And that would be a conversation with a peer who's Catholic, maybe a priest, maybe a sister, someone who can give you some guidance around that. So Islam, understanding of life and death. Life is a test from God. Each action has consequences in the hereafter. In regards to death, they return to Allah, not to be feared, but accepted. And end of life is to preserve life, but not to prolong suffering unnecessarily. Euthanasia and suicide are prohibited in the Islamic faith. Hinduism, life is an opportunity for spiritual growth and karma, moral cause and effect. Death is a step in the cycle of reincarnation. The soul leaves the body and is reborn. That is the Hindu view of death. And for end of life, it's peaceful. Conscious dying is important. So I think that's really interesting. That death should be peaceful, that conscious dying is important. It often includes prayer and rituals to help the soul transition. Buddhists, life is temporary. See, I think that's really interesting, the views of these different religions. So for Buddhism, life is temporary, it's interconnected, and it's governed by karma. Death is part of the cycle of rebirth. Consciousness moves to another existence. And end of life, for those that believe in Buddhism, that dying mindfully is essential. Clear consciousness at death helps with a favorable rebirth. And the Jewish faith, life to live righteously, follow God's commandments, and promote justice and mercy. As far as death, a natural part of life, not to be hastened, nor delayed unnecessarily. And the end of life view is preserve life when possible, but allow a natural death. Euthanasia and suicide are generally prohibited. So you kind of, as I read these again, and as I wrote these, there's a common theme here that, life shouldn't be unnecessarily with a lot of burdens or delayed, that it's a part of life. So, advanced directives and faithful planning, we've talked a little bit about this. Planning now brings peace later. And trust me, it brings peace to your family and loved ones. What is a durable power of attorney? We've discussed that. There's two of them, and today we're primarily speaking about healthcare. Who's going to make your healthcare decisions if you cannot? And remember, the durable power of attorney for healthcare only is effective when and if you are determined to not be competent, to not have capacity. So today, my daughter cannot take any action about my end of life because that advanced directives does not start for her until the day I'm incompetent. As long as I can make my decisions, I can choose CPR or tube feeding in a coma, in a sniff, if I want that. That's my decision. Discussing values with loved ones and caregivers is an act of love. It truly is. And it's a hard decision. It's uncomfortable conversations to gather the family, gather the kids, gather your friends, and say, hey, I want to share what my plans are, what my wishes are. And then another tricky thing that often people get stuck with is, who should I decide? Who's the best person to be my durable power of attorney? I remember a doctor once at Cedars-Sinai Medical Center who chose not to have his wife be his decision maker because he felt that she could not fulfill his wishes. He chose his adult son. As long as you choose the person who can commit to your wishes, and if they're along for the game here and are willing to be that person. And again, it's the person just to make that decision. It doesn't mean the person has to fully be around all the time or engaged. It's not like you're turning into their caregiver. You're just the decision maker when the doctor calls and says, what were her wishes? So when treatment becomes burdensome, okay. So if we look at discontinuing medical procedures that are burdensome, dangerous, extraordinary, disproportionate to the expected outcome can be legitimate. We really want to look at those burdens and we want to look at the expected outcome. What's the decision and what becomes burdensome? So examples of extraordinary measures: prolonged life support with no recovery. Pretty futile. And you have to remember the cost involved in all of this. A lot of people don't think of that. It's important. Who's going to pay for one to be in a skilled nursing facility? Who's going to pay for that when someone's on life support and we know there's not going to be any recovery? Invasive treatments causing great distress. Is that something that somebody chooses to have? Is that going to be burdensome? Again, who's paying for all of this? So palliative care and hospice, we focus on comfort, dignity, spiritual support. Pain relief is morally permissible, even if it may unintentionally shorten life. So I'm going to say a comment here about end of life. So when somebody's on hospice, any hospice agency, doesn't matter. Again, hospice is paid for by Medicare. You're not paying anything when you're on hospice. When somebody gets towards end of life, there's something called a comfort packet. Inside the comfort packet, and there's one in my mother's refrigerator right now, because about 6 months ago she was at end of life. And I remember telling everybody in the refrigerator, grab your orange juice, get your bagels, don't touch the comfort packet. Never touch the comfort packet. Inside is morphine, drip morphine. Inside are suppositories if someone is constipated. And then there's something called Ativan or lorazepam, which is also drop, and you drop it under the tongue. Ideally, you want a hospice nurse to be administering these medications. Well, what if you're on hospice, you're at home, but all of a sudden something turns during the weekend and you start being in a lot of pain? And the hospice nurse can't get there for 8 hours. It is okay that the family member administer either the Ativan or the hospice because they're pre-filled. Well, they must be pre-filled, right? Where there only a certain amount is to be given. Oftentimes you can get a nurse on the phone, a hospice nurse, and she or he can kind of tell you what to do. When you start administering morphine, people should know, it kind of speeds up the end of life a little bit. It's not necessarily a bad thing if the person is not in pain. And those are decisions that hopefully that person would have made to their decision-making person about what they wanted. Like, I do not want to be in pain. Like, I can tell you, I have a very low pain tolerance, and I just spiritually, I don't want to be in pain at the end of life. So give me a couple drops of morphine. If I'm in so much pain and maybe I die 2 days earlier, but that's me. That's me today. And by the way, you can always change your healthcare directives and your durable power of attorney as long as you are cognitively competent. Okay? Hospice honors the person's journey home to God. I find it to be a very intimate part of life, the last breath, which I have been at bedside with those at last breath, especially one that's Catholic, especially people that are very in their faith and believe that For a Catholic person, they're going right up to heaven to be with Jesus and God, and that's their belief system. For a different religion, as we've experienced in my slides, you may go to, Allah, you may, go into and become a cat if you believe in reincarnation, as long as it's peaceful. So, faith, community, and final witness. We do not walk this journey alone. That's my belief system. Supporting one another in prayer and presence can be very important for someone that believes in prayer, and embracing death as a transition to eternal life. And let me say something about the atheist and the agnostic. Atheist and the agnostic. Oftentimes at end of life, you'd be surprised they're asking for the priest or they're asking for the rabbi. So it's a journey kind of day by day. So some questions for personal reflection. What brings me peace about end of life? That's a question that you can ask yourself. One, what brings me peace? And my hope is that for me, that there is peace. I don't want to move personally towards death in utter terror, resentful, angry. I don't want to go to that place. I want to clean up anything in my past that is blocking peace. Do I need to forgive someone? Do I need to let go of a resentment that happened to me when I was 10 years old? Um, what about those transgressions that I've done and people have done to me? Next question is, what does a good death mean? Well, that's kind of an open answer. What does it mean? Okay, so my vision, I'm 57 years old, so I'm hoping I live another 30 years. What's that mean to me? Do I want people around my bed and, cry? What do I want? What's it mean to me? Or is a good death the kind that you choose? Meaning you choose not CPR, you choose a natural death. Is that good death? Have I started my wishes with others? Have I communicated to others what I want? Again, CPR or artificial nutrition and hydration, which is the feeding tube route. You can also choose that can be a trial period. What if there's a bad accident and you are still alive, but maybe they want to put you in a coma for a little bit on a feeding tube to see if, because what if you're not eating? What if you're losing weight? And that helps the survival of you. And you're on a feeding tube for 3 weeks, you come off and you're eating and you're doing better. So all those decisions. And what does it mean to die a holy death? Something to ask yourselves. What's a good death and what's a holy death? And at the end of the day, do we really have a say in that? We can hope, we can put it on paper about what we want it to look like. Like I give you an example. I always carry chapstick on me. There's nothing worse for me than when my lips are dry. And I literally put that in my advance directive for my daughter, that there better be a stack of chapstick near my bed to just, keep my lips moist. Little stuff like that. Prayer for a holy death. I do not fear death, for I believe in your promises. I abandon myself to your will with love and confidence. Let me spend my last moments in union with you, trusting that you will lead me safely home. And there's a lot of prayers on living, dying, and everything in between. So, in conclusion, ethical decisions at the end of life are acts of faith and discernment. Let us continue to seek God's wisdom together. And our final chapter can be a witness to grace, courage, and peace. And I am actually going to end with a personal vignette that happened about 6 months ago. I had a client in early dementia, and it was an Alzheimer's type dementia. She was 65 years old, and I had worked with her for about 4 years. So she had an early onset dementia. She made a decision to end her life by going to Switzerland, and there is a city there that performs an end of life lethal not an injection, excuse me, a pill. And she decided to go there. She was competent. She was not depressed. She was 65 years old. And she gathered her family and a couple friends. They all flew to Switzerland. They all gathered around her, and she took her last breath. And that was a very hard thing for me because I couldn't believe it. And 2 nights prior to flying to Switzerland, I took her out for dinner, and her partner, she had a male partner of 20 years that she left. And we went out and had dinner and we danced. And that's that story. And so a lot of people have different stories, different wishes that we have to honor and celebrate. So I'd like to end that, and I wanted to say that this presentation was in honor of Deborah, who made that decision. Thank you very much.
Thank you, Catherine, so much for your presentation. I know I was moved, and I'm hoping others are moved and educated. I think there might be members of the community that would like to speak, and so
Gabby, can I ask a quick question? Did everyone hear me, and were the slides moving along? Okay, good. Good. Are there any questions? I know some people are on mute or. Anybody have any questions?
Hi, Catherine. This is Chris Monroe.
Hi, Chris.
Thank you so much. Such a rich presentation, from many perspectives. Really appreciated. This is a real specific question. When you said hospice is paid by Medicare, I'm just thinking of people I know on Medicare are, I would call elders. What if it was a younger person? Does Medicare cover hospice at any age, or?
Medicare, according to the state of California, starts at age 65. And if I had a patient who had Alzheimer's disease. She was very young. She was under 65. And there was, I don't remember the exact details, but she did have to pay for her hospice care. I'm not sure if there was a copay or some of her insurance covered that, but Medicare, it was an issue with Medicare because she wasn't 65 yet.
Okay, thank you. And I understand that there are both for-profit and non-profit hospice caregivers or, companies.
Yeah, for if one wants to choose to hire, let's call it a caregiver, right? Which is the industry term for a caregiver to help one with what we call ADLs, activities of daily living, ADLs. That means that, and there's 7 of them, feeding oneself, bathing oneself, transitioning from a chair to a table, um, dressing oneself. So those are activities of daily living, which everyone can hire if they choose to. And there's 2 different kinds. There's ones agencies that are called licensed agencies in the state of California. And those agencies, by law, can only hire what's called certified caregivers. And those are caregivers, they're certified by the state of California. They've gone through background, fingerprint, training, certification, they're bonded and screened. I always tell people that have property or income, a lot of income, to hire a certified caregiver with the state of California because everyone's licensed. Caregivers, really good caregivers have, this is their vocation. They love being caregivers. They've been caregivers for 20 years. Night caregivers that only work night shifts, they're great because they don't sleep. You don't want to hire a caregiver that sleeps at night because you're paying them and you want them to be awake. Because if you were to get up in the middle of the night and run to the toilet, you want them awake, not sleeping on your couch. So caregivers who are vocational are really excellent. The other type of caregiver are the, how do I want to phrase it? They're independent. They work on their own. You have to negotiate rates with them. And in the state of California, you're considered the employer of record. You are exchanging money with them. As opposed to a licensed agency, you pay the agency. The agency then pays the caregiver. Oftentimes, caregivers can be undocumented. They can be uncertain. Well, most of the time, they're not certified with the state. You have to do all the work. You got to do the fingerprinting and the background check and all of that. There's one thing with an independent caregiver when you can negotiate the rate. So let's say they want $30 and let's say the agency wants 35. So if it matters to you, it's a risk, but that's usually the way people manage things. So that's how that works as far as hiring somebody.
Thank you. It looks like Anne Willoughby has something.
Hi, Ann.
Hi, Catherine. Can you talk a little bit about death doulas? I don't understand that term.
Very good question. They're very common in birth doulas. I had one when I had my daughter. And a doula is someone on a spiritual level that a lot of times guides you spiritually. They may be very focused on comfort care. They often work aligned with hospice. And it's more like a doula, supporting you in maintaining peace and calm at the end of life. That's really what a doula is. And there is a a certification to be a doula. So it's not like something you just want to go out and, get some sage and burn it and read some poems, and be paid for that. So there is a big push today to have more death doulas. I would say do your research on who the person is, how much experience they have, what are they going to be doing at the end of your life, what's their purpose. So it's kind of like a side thing that people have kind of come into recently. Yeah. People ask me all the time, why I present on this topic and why I enjoy it. And people say to me, I mean, I was presenting when I was 35 on the same topics, and people always thought it was quite strange that I was such an advocate in this. And I think some of it is that I've worked in hospitals all my life. I've always been on ethical bio issues, and that's very important to me. And when I was young, my grandmother had got Alzheimer's dementia at 64, and she lived 8 years. And I watched my mother, who was raising two children, a single mother, take care of grandma and take care of us, making our lunch and da 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 da, and grandma. So we would often go to grandma's house. And so I really observed the kind of care she received. She was a do not resuscitate, and we were able to afford a caregiver at the time. And whatever she wanted, we gave her. She was Irish. She loved beer. She sometimes had a glass of beer with dinner. She also liked Milky Ways. And so that was what my mother saw and what I observed. I also grew up with a father who was a pathologist. So oddly enough, when he was on call and my brother and I were with him, guess where he had to call? I'll never forget being in church and his pager would go off. And guess where we went? We went to the morgue because that's where Daddy worked. And it was a comforting place. It was a warm place. It was about, um, detecting life and death and diagnosis. And those are the two reasons why today I really advocate for what you want and how special end of life can be. And that it doesn't have to be scary. It doesn't have to be painful. And it's all up to your choice. So,
I think what you're doing is super important for a third reason, and that's because as a physician, my husband is a physician, my son is. People have this mantra: I want you to do everything possible for Dad. I want you to do everything possible for Dad.
mhm.
And by you carefully going through the what can be done and when it should be done, it's enormously helpful. It keeps people out of ICUs on dopamine and all kinds of pressors and pacemakers and ECMO and all those other things that kind of keep a biologic preparation, otherwise known as a person, going.
Mhm.
And that's what people think. Everything for Dad is very loving. When, as you point out, um, it's not always the case. So I think that third thing is really important. Dissecting out the steps and the possibilities.
Right. Thank you very much. And from a physician, you know the details of the procedure, the procedures and the treatments and doing everything sometime is the worst thing one can do. So I know it's 11 a.m. Is there any other questions?
I was
Yes,
just going to
Dorothy.
say, to prepare ourselves spiritually for the transition seems like a really important thing to do.
Hmm.
And then, okay, how do we go about that?
Yeah, that's a good question. I mean, I would maybe talk to a peer about that. Doing some free association writing that's important. Look into scriptures that may be important to you. Things like that, and what all that means. Yeah,
Thank you.
you're welcome. Okay,
Thank you so much for this amazing presentation. We will tape it. I mean, it's being taped and it could be shared. It will be shared on our YouTube channel, but if anybody wants to review it or share it with loved ones or others, I think this would be a great topic. All the topics that Catherine has done, except for the first one, has been recorded. And we have the durable power of attorney and the other paperwork that she has shared that we could share again to this larger audience. And we have one more to go. And unfortunately, I forgot to bring my sheet with what day it is. Do you know off the top of your head, Catherine?
I'm afraid to bounce out. I may not get back.
Okay.
So I
Come,
believe it's
come.
in July. And also there's a
Yeah.
handout. There should be a handout on your table that
Mm.
I created. I don't know if it's there or not.
It is, and we'll make sure that it gets sent out to everybody as well.
Wonderful. And for
Um,
Dorothy, that's similar that I know, oh, wait a minute, you're Zooming. So we can get that to you, that handout. And it gives kind of an option to kind of write some things down that are important to you.
So for everybody online, thank you again, Catherine. For everybody online, stay around your computer. Come back at noon for the lunch and learn, and we'll see you soon.
Thank you, everybody.
Thank you.
Thank you.
Oh, I've just been told it's a separate Zoom link, so go back to your email and find it. Come at noon. Thank you.
And
Bye-bye.
maybe, Catherine, maybe that handout could be put online for community members. That would be great.
Yes, and I sent that to Pam, so I'm sure that can be forwarded.
Oh, thank you.
You're
Thank you very
welcome.
much.
Goodbye, everybody.
Bye.
Be
Bye.
well.